Hello everyone, thank you for joining. Today is June 13th, 2023. Welcome to the Regimen, where public health pharmacists, pharmacy students, and our guests discuss the latest public health issues. Listen to learn how pharmacists and pharmacy students like us can improve population health, health equity, and patient care through advocacy and education. My name is Ashley Shirello, a doctor of pharmacy student in my final year at the University of Rhode Island, working with Dr. Bratberg as well as the Rhode Island Department of Health.
All right, and I'm Jeff Bratberg. I'm a clinical professor of pharmacy practice and clinical research at the College of Pharmacy and an academic collaborations officer at the Department of Health. As a reminder to our listeners, the opinions expressed in this podcast by the hosts and the guests do not represent the opinions of the United States government, the Rhode Island Department of Health, nor the University of Rhode Island.
Thank you, Dr. Bratberg, for the introduction. I hope you're excited about today's discussion in regards to the pharmacist's role in breast cancer screening and prevention, as well as the newest recommendation for mammogram screening to begin at the age of 40.
Yes, it's great. Today's speaker is Dr. Brown. She's going to be called Britny today. Britny is a board-certified oncology pharmacist, a professor at the University of Rhode Island, an alum of the University of Rhode Island College of Pharmacy, and also a faculty advisor for the National Community Oncology Dispensing Association student group. Thanks so much for joining us today. Introduce yourself to our listeners and make sure that we have your students who are here too to introduce themselves.
Absolutely, yes. Thank you for the introduction. I'm Britny Brown. I'm a clinical associate professor at the University of Rhode Island, as you mentioned. And I do have a clinical practice site at Smilow Cancer Center at Westerly Hospital currently, where we focus on oral anti-cancer therapies encompassing all sorts of different types of cancers. I trained in oncology in Buffalo at Roswell Park Cancer Institute, Go Bills. Since then, I've had a myriad of different experiences, but largely mostly focusing on oral anti-cancer therapy.
We are also joined today by Cassie, Capezza, and Erica Lee, two doctor of pharmacy students at the University of Rhode Island. Cassie and Erica, please feel free to introduce yourselves and tell us about your rotation experience.
Hi everyone, my name is Erica. The rotation is going well and I'm grateful for the opportunity to work in such a meaningful field with Britny. We were able to participate in chemotherapy management in different types of cancer, provide counseling to patients who are starting their new oral chemo regimen, work closely with oncologists as well. I've learned a lot from the past 3 weeks I spent at the Smilow Cancer Center, and Cassie and I can't be more grateful of the experience we get to have with Britny. It's truly inspiring to see the impact we have on the patient's life.
Hi, my name is Cassie Capezza. I'm in my last year at URI's College of Pharmacy, and I'm currently an API student at Smilow Cancer Center at Westerly Hospital. I'm a member of the NCODA in URI's chapter and am interested in focusing on oncology moving forward in my career.
Thank you for joining us today. Let's first give our listeners an introduction to breast cancer. Breast cancer is the second most common cancer affecting women in the United States. The American Cancer Society estimates that there will be over 297,000 new breast cancer cases in women in the year of 2023, and over 43,000 deaths due to breast cancer. How can we reduce the amount of new breast cancer cases in the future? It starts with education. According to research, early detection and screening is essential. Over 90% of breast cancer malignancies can be cured if found early on. That being said, it is important that both healthcare providers and our patients understand the early signs of breast cancer. What are some common risk factors that those assigned female sex at birth should be aware of in terms of breast cancer?
Thank you, Ashley, for that history. When people think of breast cancer, they normally associate it with a family history. However, 80% of women diagnosed with breast cancer actually lack a family history. So factors that could put a person at increased risk for the development of breast cancer include largely estrogen exposure. So this is experiencing menopause at a late age or the occurrence of menstruation at an early age, as well as having your first live birth at a late age, which is determined to be greater than 30, which could be a whole nother discussion, or never having children, as well as dense breast tissue, the use of oral contraceptives, which is a mildly increased relative risk, as well as a diet high in fat or alcohol, lack of exercise, past exposure to chest radiation, and exposure to pollutants in the environment.
And what should women do to prevent or detect early breast cancer?
The American Cancer Society has several recommendations, largely mammograms, clinical breast examinations, and maintaining breast awareness, which would mean signs and symptoms of breast cancers. Historically, we thought of maintaining awareness as self-examination, but that's actually fallen out of favor. And now we're just informing the general public about signs and symptoms so that when they're carrying out their daily activities, they're able to see these signs. They include things like breast swelling, irritation or dimpling, breast or nipple pain, also inversion of the nipple, so turning inward, as well as redness, scaliness, or thickening of the nipple or breast skin, as well as discharge from the nipple other than breast milk and a lump in the underarm area. In addition to that, for people with a strong family history of breast cancer, it might be recommended to undergo genetic testing or potentially counseling for those with a known risk or family history of mutations such as BRCA1 or BRCA2.
How often and why should breast examinations be performed?
Well, that's kind of the million-dollar question right now, so there's a lot of controversy we'll go into. However, we do know that beginning at the age of 25 for average risk people, they can begin clinical examinations, and those are recommended to occur between every 1 to 3 years, and typically are done either at the gynecologist's office or with your primary care provider. Beginning at the age of 40, breast examinations are recommended to be performed at least once a year, and some guidelines also recommend mammograms at least once every year or every 2 years.
The United States Preventative Service Task Force has recently made an update to the recommendations for mammogram screening to begin at the age of 40 instead of age 50. What is the reason for lowering the age of recommendation, and what do you think of the benefits and limitations of lowering the age?
You know, I'm actually really glad that we're talking about this because I hadn't truly dived into the recommendation until we decided to hold this discussion. And the current recommendation from the USPS task force is technically in draft form. They recently solicited feedback and are collating that feedback to formally publish something. The bulletin that was released in May of 2023 is a summary of the recommendation. In that, they specifically call out health inequities as it relates to breast cancer outcomes. Specifically, as many of us know, Black women are more likely to die from breast cancer than white counterparts. There are additional health inequities associated with ethnically and racially minoritized individuals such as Native American, Latinx, Asian and Alaska Native persons. However, whether or not this is clearly correlated to screening is unclear. It appears that the major reason for encouraging early detection via screening mammograms is because of this health inequity. And reading through the data that they collated, that is what they summarize. However, there's no new data and no additional information that tells us that screening at age 40 decreases these negative health outcomes.
So that's fascinating, and one of the things we focus on in the regimen is health inequities, so I'm really happy you brought that up. Is that something that you see in your practice or something that you saw in your training where there are minoritized populations presenting with later stage cancer or even dying of it more frequently?
Unfortunately, yes. So at my previous practice site at Women and Infants Hospital, I primarily saw gynonc and breast cancer patients, especially when there were many levels of barriers to healthcare, such as primarily Spanish speaking or race or ethnicity that was historically marginalized, maybe a level of distrust with the healthcare system or mistrust, which is completely rational in a lot of scenarios. There were instances where patients were diagnosed really late. Prime example is cervical cancer. We know in rural countries that this happens often because they just don't have as much access to things like screening pap smears and HPV vaccinations. So we do see those barriers and disparities persist in minoritized populations, unfortunately.
I think you were presenting sort of both sides of this early age screening mammography recommendation. Do you want to continue with that?
There's really no new data. Theoretically, they are essentially stating that the potential benefit of screening earlier would help to capture some of these people who are lost to follow-up or aren't getting appropriate screening, and ideally detecting cancers at an earlier stage. The thing that they're extrapolating is that detecting it at an earlier stage would help to decrease the progression to a later stage cancer. The counterpoint to that, the most recent Cochrane analysis on this topic regarding mammography screening and cancer outcomes as well as all-cause mortality was performed in 2013, so it's due for an update. In this Cochrane analysis, they identified that neither breast cancer or all-cause mortality was reduced with mammography. In fact, the trend that we're seeing is that as our treatments for breast cancer improve, mammography screening has diminishing benefit on outcomes. I'll also have Cassie dive into some of the other limitations of mammography screening.
Breast cancer screening may begin at age 40, but it should definitely be an informed discussion between the provider and the patient, because although there are many benefits associated with this screening, there are also some risks to be aware of. These risks include false positive screenings, added costs to the healthcare system and the patient, and potentially overtreatment of the breast cancer cases, which would not have otherwise been found without the screening. False positive cases would include instances where mammography or other breast cancer screening demonstrates abnormal findings or imaging, which would then be diagnosed as benign in subsequent biopsy, showing that this would be an added cost and added time to the patient and the healthcare system. Breast cancer screening can also lead to the discovery of indolent breast cancer cases, which means that a patient could live a long, healthy life without ever realizing they would have had this cancer. In these scenarios, patients can be treated in a case that would never have progressed to be an issue to begin with. This would result in decreased quality of life from unnecessary cancer treatment. For example, we can't say for certain that an asymptomatic finding which results in aggressive treatment with chemotherapy would have otherwise been fine if it was left untreated. We also know that cancer treatment itself isn't without risks, which include side effects and financial burden to the patient and the healthcare system. Although we've made progress in determining who is most likely to benefit from the treatment and the screening, there are also still some cases where we treat with radiation, surgery, and chemotherapy when we don't necessarily have to. All of the risk factors, or these risks that we discussed associated with breast cancer screening, are a reason for us to discuss if breast cancer screening is beneficial for each individual patient.
Thanks, Cassie. I just want to remark on one thing. You talked about unnecessary biopsies being costly and inconvenient to the patient. I mean, there's a significant risk to that. Any of you want to talk about that?
There's obviously a lot of anxiety, too, associated with having biopsies done or being referred for a biopsy. It can be very painful. It can take a long time for the feeling of that biopsy intervention to resolve. There's certainly costs associated with it, not just with having the procedure done, but with time missing work or other things they might have to miss, childcare, whatever it might be. And then, of course, if there are, this additional suspicious lesion turns out not to be a cancer, then those are all things that they've now gone through that they didn't necessarily have to. And whether or not that's because of the additional screening is another question that we have.
Yeah, I like the mental health aspect of the anxiety of anticipating the procedure and anticipating the results. Do you know the average time between the procedure and when the results come in?
That's a good question. It would completely vary upon where you're having it conducted and the department that does the pathology. But I would say anywhere from a few days to a week, potentially more, depending on holidays and vacations.
Right. So I think it's good that we have this discussion of a lot of people listening have lots of privilege and going to the doctor is just sort of an inconvenience, and we can schedule our day around it and we have coverage. But then there's this other thing you talk about, mistrust in the medical system, and every time you add one of those interventions, you're being exposed to that system that may not be a positive.
I was wondering, what exactly are three-dimensional or 3D mammographies?
That's a great question, and another one that I'm really glad we're talking about this, because I got to dive more into the differences and changes that have happened over the last decade with mammography screening. When most of us think of mammography, we think of old school, just limited one picture view of the breast tissue. So 3D mammography is more of a kind of moving picture or multiple pictures that looks at the breast from a variety of angles to create a more detailed image. And due to the 3D format, it's better able to distinguish between cancer and normal or dense breast tissue. So it certainly helps individuals who have a history of dense breasts and potentially being referred for additional screening or testing, such as biopsies. And so those who traditionally get it or would benefit from it would be those who might have dense breasts or history of having to go back for further testing.
Has there been an increase in early breast cancer diagnosis since the introduction of 3D mammograms?
Absolutely. So great question. And yes, this has kind of fallen into favor for the majority of institutions that are doing breast cancer screening. From what I've seen, it appears that 3D imaging, or tomosynthesis as it's also referred to, is kind of the standard of care or the standard practice at this time because we are increasing the detection of breast cancers. So it is more sensitive to be able to detect breast cancer. However, that hasn't translated yet, or at least there's no definitive data to suggest that it decreases cancer-related mortality or overall mortality.
3D mammography is especially useful in detecting breast cancer and dense breast tissue due to their ability to take pictures from numerous angles. Have we seen an improvement in detection for those with non-dense tissue as well? And are 3D mammograms geared towards this population, or are we seeing a switch from all mammograms to this 3D technology?
That's a really great question. So about 50% of women do have what's classified as dense breasts, and those persons are most likely to benefit from having this 3D mammography screening. However, what I've seen in my limited experience is that most institutions are just taking a one-size-fits-all approach and universally doing 3D mammography. It's possible that not all persons actually need 3D mammography, but that's not something that it seems like is being risk stratified at this point. And as far as I can find, and to my knowledge, the benefit has not been seen with patients with non-dense tissue.
So that's interesting. Of course, the elephant in the room here is the insurance carrier. So,
yes.
You can see it one way to say, well, it's great that we're having universal fit, and, we get those 50% of women who have dense breasts. But if we're using an inappropriate technique that perhaps is more expensive or timely and doesn't have the outcomes, maybe you don't know this answer, but it's interesting to see that insurance is paying for this for everybody.
Correct. Yeah. From my understanding, you're right. The copay is probably different. Do the patients know that?
No,
Probably not.
Not given the option, right?
Yeah.
To
So
say,
Women and Infants is only conducting 3D mammograms.
Oh, okay.
And so essentially patients who are screened at that institution are required to get 3D mammography, regardless of what their insurance copay would be, one versus the other.
Oh, wow.
I can't comment on whether or not they are different, but I suspect that they would be because it's newer technology.
And I guess this is sort of a discussion point, is if it's beneficial, like we talked about this with formularies for drugs, right? We don't want to carry 4 forms of the same thing,
Mm-hmm.
and if one's marginally better but is less times a day, there's a cost potential benefit there. There might be a cost benefit to the workflow to say, if you come to our institution, you need this thing, we know how to do it, we're very skilled at it. We don't have to have another machine in another room. We're not experts in this podcast in mammography, we're not radiologists. Someday We'll have one on, but I think it's important to do that.
Thank you for taking the time to discuss the risk factors associated with breast cancer, how women can contribute to early detection of breast cancer, and the transition we are seeing from 2D to 3D mammograms. This being said, it is important that healthcare providers are able to pass this information on to their patients.
So Ash, what is a community pharmacist's role in breast cancer awareness?
Community pharmacists can contribute in areas such as educating patients about possible signs and symptoms of breast cancer, informing them about the importance of breast examinations, and counseling patients on their current cancer treatments. I wonder what needs to be done in the community pharmacy setting to assure that our pharmacists understand the basics of breast cancer and communicate this with our patients. The 2022 study surveyed 605 community pharmacists. Their findings were that nearly 3 in 5 pharmacists felt that a drawback to their knowledge of breast cancer was due to the lack of access to educational materials. What resources and sites would you recommend to pharmacists, healthcare professionals, and students looking to learn more about breast cancer and how to correctly educate their patients?
Great question. I think that the American Cancer Society at cancer.org has really great information both for patients and healthcare providers. I also find that the NIH, National Cancer Institute, at cancer.gov has a lot of great information as well. These are easy to follow, I think, for both patients and providers. In addition, if you really want to dive deep, you can review the NCCN screening and treatment guidelines for breast cancer. They do have guidelines for both patients and healthcare professionals. This is, pun intended, more dense, so a little bit harder to read through if you're not familiar with NCCN, but worth the read if you want to dive more into the literature.
I think that it's clear that pharmacists have an important role to play in breast cancer. The breast cancer risk assessment tool, also known as the Gale model, is used to assess one's relative risk of acquiring breast cancer. The model considers a woman's medical history, reproductive history, and family history to estimate one's 5-year risk of the development of invasive breast cancer. How can this model become implemented in the community setting?
So in order to estimate the risk of developing invasive breast cancer, the Gale model uses a woman's own personal information, including age at the start of menstruation, age at first live birth of a child, number of first-degree relatives like mother, sister, and daughters with breast cancer, and also number of previous breast biopsies, whether positive or negative, and presence of atypical hyperplasia in the biopsy as well. Like you mentioned, Ashley, this tool identifies a person's 5-year risk of breast cancer. So if the risk is greater than 1.7% in individuals older than 35 years old, the recommendation is to pursue annual screening and clinical breast exams. The model contains less than 10 questions and helps screen out individuals that are not appropriate for the risk screening tool. And I believe that pharmacists and other healthcare professionals in the community settings and in the transition of care setting before hospital discharge could assist patients in collecting data to complete the risk score and recommend follow-up with their primary care provider.
Is this tool commonly seen in practice, and what do you think about the accuracy of the tool?
That's a good question as well. In my experience in community oncology, I frequently see the Gale risk score being utilized to guide screening and prevention decisions. However, I'm not working in primary practice, so in my limited experience and interface with that, I haven't necessarily seen it used throughout practices. So I do think there's ample opportunity to increase its use in healthcare settings. In terms of the accuracy of the tool, it's been well validated in white patients. Unfortunately, there are some risks associated with using it with other marginalized populations. It has been studied in Asian and Pacific Islander women as well as Black patients and Hispanic people using data from the Women's Health Initiative. So it performed well in those populations, but unfortunately it might underestimate risk of cancer associated with Black women as well as Hispanic women. And so it does need to be further tested and validated in those populations.
Sounds like that's another role for pharmacists, right? Our NCODA folks, here's your thing. Let's validate this in the populations who are most affected.
That's a great point.
What other contributions do you believe would be beneficial to add to the screening tool?
Going off of what we just said, those specific populations are Hispanic and Black. It would be nice to further elucidate how we can make it more accurate for those populations. And then I do think it's important to note that the Gale risk screening tool doesn't apply to those with a history of breast cancer, history of chest radiation, or those with genetic syndromes. And those populations might be able to be screened with alternate screening tools.
Thank you for the insight. I think that screening tools are a great starting point when determining a person's risk factors. Not only are they accurate, but they are easy to use for both professionals and patients. Studies support that the introduction of tamoxifen into a high-risk patient's medication regimen reduces the probability of developing breast cancer by about 50%. With the scope of the pharmacist expanding, do you suspect that we will be able to implement the Gale model to provide prescribing and distribution ability to community pharmacists for medications such as tamoxifen to prevent breast cancer in high-risk patients, who are those with at least a 1.67% 5-year risk for development or 20% lifetime risk? What would need to be implemented in pharmacist training if this was to become a standing order?
Wow, this would be amazing. I do think I have some hesitations, right? The first thing is anytime you add a pharmacist service, there needs to be a reimbursement model in place. Following that, I think pharmacists are really well equipped to navigate the Gale risk model with their patients. They can help them walk through the questions and make sure they're being answered accurately. They receive a lot of information in their regular PharmD training. So we go over drug-drug interactions with tamoxifen, and pharmacists are arguably the most well-equipped to manage those. They would be familiar with, I think, risks associated with tamoxifen treatments such as VTE and endometrial cancer. And because they're such a highly available resource compared to other healthcare professionals, I think they'd be a great person to help patients navigate follow-up care with gynecologists, for example, to be screened for endometrial cancer. I do think pharmacists are well-equipped, and I'd probably be amiss to miss the fact that pharmacists also can help improve adherence, which is something that's often underlooked in healthcare provider practices. So we might even be better than other healthcare professionals in just prescribing tamoxifen.
100%. Of course, we're the best. This is the Regimen, and we are the best.
We're not biased, though.
We're the best at all things. I have another unintended follow-up here, but
yeah.
So your focus is oral chemotherapy, and you're talking about adherence, and I'm sure you talk about tamoxifen. Like, what do you do to ensure, what do you and your students do to assure adherence of these, complex regimens some with lots of side effects, some with severe side effects?
It's a very great question, and another $1 million question. There's a lot going on, I think, in this space right now. Oral anti-cancer therapies have really taken off. We have a lot of strong data in certain disease states like CML that says for patients who miss 1 out of 10 doses, they have significantly worse outcomes. So right now, with the resources we have, with the help of students, we try to target populations at greatest risk for non-adherence. We first identify, who do we think those populations are. So CML, we certainly target and make sure we're asking them regularly, how many doses have you missed? Why do you think you've missed them? And help them navigate tools to help them avoid that in the future. What I've seen and what I'm really interested in looking more into is patients might have additional barriers to accessing their medications. So I think there's a health equity avenue here, right? People who might be underinsured or uninsured are less likely to be adherent to their medications. Drugs that have limited distribution access, like IMiD therapies, are another area that we are specifically focusing on. So we're essentially performing additional outreach to patients to make sure they get their drug, they get it on time, that they're taking it appropriately. As far as I can see in my review, we're the only person that's regularly asking about adherence in our clinic, which is not a standalone one-off. That's pretty much diffused throughout practices.
So Erica or Cassie, what have you found in terms of, you've been taught adherence the last 3 years, so what, now you're in your first API rotation with these important medications, any anecdotes or anything you'd like to share in terms of patient interactions or things that...
Erica, do you want to share a little bit about your non-English speaking patient?
I've realized that with the chemotherapy, like with the chemo medications, many of them cannot be filled from like regular pharmacy, that they have to go to either like Yale New Haven specialty pharmacy or just like other CVS specialty pharmacy, which can take several days or more than a week, for the medication.
And they're mailed to them, right? You're not interacting with the person.
Right.
Yeah.
So in order for them to in order to make sure that our patients get the medication in a timely manner, we usually communicate with the patient and also with the specialty pharmacy. And then last week, what I have realized is that I called one of our patients whose first language is not English, and he didn't know that he had to call the CVS pharmacy in order to arrange the delivery date, arrange to make sure that everything's going straight. So first, there was a language barrier, and then second, he didn't know that he had to get the medication as soon as possible in order to start the medication therapy. So language barrier is definitely a barrier.
Cassie, anything on your mind?
Yeah, I can add a personal experience through our outreach in the same scenario. I feel like there are some gaps where pharmacists can kind of step in between the provider and the patient, where patients may have difficulty or additional barriers getting their medication. So for example, the other day, a patient needed to receive a prior authorization to get one of their medications, which was not completed. So my preceptor, Britny, was able to step in. This wouldn't normally be her role, but she completed the prior authorization so that the patient was able to get the medication within like a timely order.
Yeah, I think it's really important for our listeners to realize that in lots of other disease states, we have patient navigators. So my experience is Hep C, and we have a regimen on that, and trying to reduce prior auths again, in a different sense, since you can cure Hep C almost 100% of the time if you get the meds, to eliminate prior auths. And there's actually legislation that has gone through about that in Rhode Island. So I think it's really interesting that we hear these sort of portraits of people, and to, again, really reflect on ourselves, to go, okay, it's inconvenient to go to CVS and see someone super busy or some other pharmacy. And what we've done on the regimen is to advocate for payment for all these services, so that we have technicians and navigators and social workers and really this whole interprofessional team, ideally. And I know that's been studied in oncology care, clinical care. So I think it's really exciting that as these therapies expand, if you go to the infusion clinic, you don't have to wait to get a prior auth on your infusion, right? It's inconvenient, or you go to get radiation, you're not waiting there for a prior auth. But if you have a language barrier, you may not know where you're going, or you may not know which seat to sit in. With oral meds, it adds that level of complexity that I think we need to study and keep working at these excellent interventions you're making to make sure patients get their care.
So what a great discussion on this week's episode of The Regimen. I sure learned a lot about breast cancer, and I hope that our listeners can say the same. I would like to thank our guest speakers, Britny, Erica, and Cassie, for their time today and for providing such great insight in regards to breast cancer.
Be sure to follow @PharmD_Pub_Health on Instagram, Twitter, LinkedIn, and YouTube. Turn on post notifications so you never miss an episode. Smash that subscribe button on Spotify, Apple Podcasts, YouTube, and Amazon Music, or wherever you listen to podcasts, to hear the latest updates. Thanks so much.